In order to appreciate the differences between PAV Plus and pressure support ventilation, it's important to compare the way that each of these modes function. In this section, we'll be reviewing pressure support ventilation and discuss how the respiratory center may interact with this mode. In this slide, we will review the basic operation of a pressure support breath. For demonstration purposes, the strength and duration of patient effort throughout this presentation is represented in solid green under the pressure waveform as shown here. Here you can see three pressure support breaths with varying patient effort. Regardless of the patient effort, as long as the trigger sensitivity criteria is met, the inspiratory phase begins and the circuit pressure increases by the set pressure support level. The resulting difference in pressure between the circuit and patient airways drives flow into the lungs, and importantly, the inspiratory phase continues until the flow termination criteria is met. Notice that on the first breath, a tiny inspiratory effort, or even a strong cardiac oscillation, can trigger the breath and potentially generate a significant tidal volume. I've personally witnessed heartbeats trigger pressure support and result in tidal volumes of 400 mils, 500 mils, or even higher, depending on pressure support setting and patient compliance and resistance. Now let's have a look at an example of how a patient's respiratory center may interact with pressure support ventilation. In this case, based on the pressure support level set and the patient's respiratory mechanics, a weakly triggered breath, or even an auto-triggered breath, is providing a resting tidal volume of 500 mils. Now let's say the patient's respiratory center is only targeting a 450 ml breath. Even with an effort well below normal, the tidal volume demands of this patient are being met. What would you expect the resulting feedback to be from the respiratory center for the next breath? A, work harder, B, work less, or C, stay the same. You'd probably agree that it's not likely to be work harder since tidal volume demands are already being met, and that can put this patient at risk of significant diaphragm atrophy even while on a spontaneous breath type. On the other hand, if the tidal volume demands of the patient are not being met, something entirely different may happen. In this theoretical patient, the resting tidal volume with minimal effort is 400 mils, but the patient's respiratory center wants 450 mils. Since the tidal volume delivered is lower than the demand, this patient's respiratory center increased effort on the next breath. This increase in effort resulted in an overall increase in the total pressure gradient driving the breath, so flow increased, just as you'd expect. However, since the increase in peak flow also increased the flow termination criteria, the result was a shorter inspiratory time and a smaller tidal volume. The respiratory center responded to this by generating an even higher effort on the next breath, again increasing the peak flow and once again shortening inspiratory time and decreasing tidal volume. Eventually, this patient was able to make a large enough sustained increase in effort to get the tidal volume that their brain wanted, but it required an effort well above normal. And as we discussed in an earlier section, excessive diaphragm effort has been shown to cause injurious diaphragm thickening that increases the risk of prolonged mechanical ventilation. Now that we've had a look at how the patient's respiratory center may respond to pressure support ventilation differently depending on whether the tidal volume demands of the patient are inherently being met, let's look at how this could affect a pressure support wean. Our patient wants a 450 ml breath throughout this weaning process, and you can see the tidal volumes that were inherently provided as we decreased the pressure support level from 20 all the way down to 6 centimeters of water. Notice that almost every time we drop the pressure support level, the resulting tidal volume goes down as well. Some clinicians may think that as the pressure support level is dropped, it forces the patient to increase their effort. If that were the case, every time we lower a pressure support setting, we would expect to see an initial drop in tidal volume, and then as the patient increased their effort accordingly, the tidal volume would recover to the original value. Now consider how frequently you actually see that happening in practice. If you drop the pressure support level and see a resulting drop in tidal volume, but you don't see a subsequent increase back to previous levels, isn't it more likely that the patient hasn't changed their inspiratory effort level? In this example, so long as the resulting tidal volume after a drop in pressure support setting is has met the patient demand, there was no reason for the patient to increase their respiratory effort. However, notice that when we get to a pressure support level of 8, this patient had to make a significant increase in effort, as discussed in the previous slide, to get the tidal volume that the respiratory center wanted. When you look at pressure support wean from this perspective, doesn't it seem likely that if tidal volume demands are being met, the patient may be at risk of diaphragm atrophy, while if the tidal volume demands are not inherently being met, the patient may be at risk of injurious diaphragm thickening? I'll end this review of pressure support ventilation with a quote from Moore's 2012 paper in Critical Care Medicine. With clearly proven drawbacks of conventional assisted modes such as pressure support ventilation, it is probably about time to leave these modes introduced decades ago behind.